So the question was, is traditional trabeculectomy still the gold standard?
Yeah.
So gold standard dictionary meaning is perfect or cannot be improved upon. So in medical terms, so essentially something which is a standard at the current times, which is giving reliable results, and against which all newer techniques are compared, is what gold standard in medical terms means. Our aim is to preserve visual acuity and vision fields as well as quality of life, and try and spare the patients from any additional anti-glaucoma medication and their side effects. So that is what your surgery should be giving them. So the technique should be standard, reproducible, have a good success rate, and should flatten the diurnal curve, low complications, and minimal or no follow-up interventions. It should be inexpensive so that it is applicable to a larger population. So let's look at these standards in trabeculectomy. What is standard about it? Starting from conjunctival flaps to how you open it, whether you augment it or not, how you make the scleral flap, what shape it is, what size you make the ostium, whether you use a punch or not, nothing is standard. And all of us, me included, feel that whatever way I am doing it is the correct way, but nobody has any one standard technique. So there's nothing standard about it. The postoperative follow-ups are huge, and 80% of the work in trabeculectomy is to achieve a good result is in the postoperative care, with large number of complications that are likely to happen, and it's a ticking time bomb. We are waiting. Is the chamber going to shallow? Is it going to overfilter? Is there going to be a leak? Will it have choroidals? Then will the hypotony cause vision loss? There's so many things. And it doesn't end there. It's six weeks you think, okay, I'm through now, and then you have to keep following them up because blebs might sweat, they might leak, they might get endophthalmitis, they might underfilter, there might be multiple. And after all this, if you look at the success rates, most of the studies show that at the end of 5 years, 50% of them are not functioning, you're back to giving them medication. So really if this is the standard we are going to reach up to, this is really worrisome then. If you look at the comparison of the various surgeries that are now available, you'll find that the only thing that trabeculectomy has going for it is, one is that it is not requiring many investments, and secondly, because this has been there for such a long time, we know what to expect from it, while all the others are not here for a long time, so the long-term efficacy has not been proven. But if you just take safety as a factor, and if you look at the efficacy along with it, and the fact that most of the surgeries anyways need post-op medication at 5 years, then you might find that a lot of these newer procedures are much safer as compared to trabeculectomy. So if you ask me, there is nothing gold or standard about trabeculectomy. It is just that it is a known devil, and we are all used to it. It is inexpensive, and most of us can safely do it in our do it in our practices. That is why, because we haven't found something to fit the ideal new all criteria, that is why we do not have a new gold standard, and therefore we still think that trabeculectomy is the gold standard, but it is neither gold nor standard. Thank you.
Thank you, Roopali ma'am. And I would like to take the expert opinion from Dr. Deepanjan sir. What is his take, that whether, what does he want to convey to the audience?
Yeah. Yes, Roopali was excellent, because it is definitely, it's a difficult against the motion. But one thing is for sure, that we cannot compromise on efficacy as thinking a procedure to be safe. If the procedure is just based on safety, we cannot compromise on efficacy. So we have to look to those days where the other procedures will compare to trabeculectomy with mitomycin C. It will be as efficacious, because trabeculectomy as mitomycin C has shown us that the intraocular pressures are going to be controlled over years, like more than 10 years. It's the longest study has already come. So, and we have enough ideas in our brain to understand that it can be safely done without much problem. And newer, safer methods are coming. And if we feel that mitomycin C is not good enough, we can shift to Ologen also. But Ologen is not, again, I think in long term, Ologen might not be as effective as it is not in supply at all right now. but it has given some idea that you know, it is probably is a good adjunctive when it is compared to. Then again, we are coming to the same point that we are compromising on efficacy, and we are thinking on safety profile. So that is my take.
Yeah. Also that if you look at everybody says qualified success, but if you look at all the long-term studies,
Yes.
they always use 21 millimeters of mercury as
mercury
their
as a-
success rate.
yeah.
I mean, who would do a trab if you needed to get your pressure to 21? It is like we want our pressures to be 12 and 14.
12 and
then
14,
if you look
yes.
at it, it is not really that great a procedure.
Yeah.
So thank you. It was a very nice discussion. So at the end of this particular debate topic, I would like to convey to the audience that yes, trabeculectomy, definitely it is the initial procedure. It should be initial procedure, and the indications are different from trabeculectomy and MIGS or any other conventional procedure, any procedure you want to do. It entirely depends on the condition of your patient, the status of the ONH, the pressures and everything. If higher pressure reduction is required, trabeculectomy is definitely going to be a treatment of choice. And if you want to go for moderate glaucomas, then probably MIGS or any laser can help you out in that. So at the end, now we like to conclude this session since